So we're going to continue on talking about various parts of the IVF cycle, and the first bit that we're going to talk about today is the one that is the most highly variable, and that is ovarian stimulation. Now, this, as I said, is highly variable, and in many clinics, they are essentially kind of bespoke cycles that are tailored to an individual. It has the most amount of change, and it really is different for different people. And this is where terminologies like short cycles, long cycles, ultra longs, all of that stuff is thrown about, and they all refer really to this part of the IVF cycle, that is ovarian stimulation, growing the eggs or the follicles. Now, despite their variability, despite their heterogeneous nature, and despite the differences between all these types of cycles, they all have a couple of common elements. One is that they all work with eggs that are currently available in the ovary, and there is another video that I did that talks about that. Two, they all contain a type of medication that stops the ovary from prematurely ovulating, and they have a type of medication that grows the eggs. Now, the first medication is necessary because we essentially want complete control of the growth of these follicles. Based on our blood tests and based on our ultrasound, we want to make the determination of when is the best time to mature the eggs and collect them. So we really don't want the ovary or the body to randomly ovulate an egg before we're ready. Now, let me be clear. If an egg ovulates, that egg is lost. And often ovulation events don't affect just one egg, they affect the whole batch of eggs. So if there is premature ovulation, then that cycle is essentially all moot, and we need to start again. So preventing the ovary from prematurely ovulating is really important. And we do this via two types of agents, and again, different brands, different types of medications, but they come in two broad types. One is called a GnRH agonist, and the other is called a GnRH antagonist. GnRH antagonists are used in short cycles exclusively. GnRH agonists are used in long cycles and short cycles. One is a little bit more long-acting, than that is the GnRH agonist, and the other one is a little bit more short-acting. But they essentially both do similar things, that they try and suppress the ovary from ovulating. In doing so, however, they also suppress the body's endogenous production of hormones that grows the eggs, which means that we need to replace that medication, which leads to our second drug, which is the injection that we give on a daily basis to grow the eggs. These are replicates of body's own hormone, but we give it in much higher amounts so that more eggs are recruited and grow, and more eggs can be retrieved. The hormones are generally follicular stimulating hormone variants, so FSH. These can come from different sources. They can come from what we call recombinant technology, which is actually much more close to the molecules that are produced by our own bodies, or they can come from urinary technologies. The length of stimulation will depend from person to person. So generally FSH is given for at least 8 days, because we think that that is actually the number of days it takes for an egg to develop competency and mature. But depending on the person, it can go generally beyond 20 to 25 days sometimes, but most people tend to have about 10 to 15 days of injections. So that is what generally happens during ovarian hyperstimulation or controlled ovarian hyperstimulation. In terms of which cycle is better for you, it really is dependent on the individual, on the individual. I think if you look at big data and high level picture, longs, shorts are all the same. They tend to give similar live birth rates. Where they differ are different types of patients with different reasons for needing IVF, and that's where that individualization of protocol becomes really important.